Thank you for the introduction. Like you said, my name is Dan Landup, clinical pharmacist with Advocate Medical Group. And our goal today is to unfold cardiac amyloidosis, and with the first half of the webinar, talk about the background and treatment of this disease. I have no relevant disclosures. So the first half of the webinar, the goal is to review the pathophysiology, signs and symptoms, and the diagnostic pathway for suspected cardiac amyloidosis, and then discuss the available treatment options for amyloid cardiomyopathy. So what is amyloidosis? It's really a broad term that's used to describe a condition that's characterized by abnormal protein misfolding, in which there is an unstable precursor protein that misfolds, aggregates, and then forms insoluble amyloid fibrils, which then deposit in the extracellular space of various organs and tissues, which then affects their structure and function and then leads to clinical disease. Although there are more than 30 different precursor proteins that can cause amyloidosis, luckily for us, cardiac amyloidosis, also known as amyloid cardiomyopathy, is predominantly caused by either transthyretin deposition or immunoglobulin light chain, which together accounts for more than 95% of the cases. So the two subtypes we will talk about today, again, is immunoglobulin light chain, or AL amyloidosis, which was previously known as primary systemic amyloidosis, and then ATTR amyloidosis, which can be further characterized into wild-type TTR, which results from the deposition of a genetically normal transthyretin protein, and then variant TTR, in which there is a genetic mutation in the TTR gene that leads to an unstable protein. So there are a few differences I want to highlight between the two. AL amyloidosis is a bone marrow problem, which there is a plasma cell dyscrasia. It does carry the worst overall prognosis, with life expectancy around 4 to 9 months once heart failure is present. And then the mainstay of treatment is with chemotherapy. In contrast, ATTR amyloidosis is a liver problem, caused again either by the wild type or the variant forms of TTR that's produced in the liver. It does have a more favorable prognosis, anywhere between 2 to 6 years, depending on a specific mutation, the stage at the time of diagnosis, and the degree of cardiac involvement. And the treatment is either aimed to prevent TTR production, stabilize the existing TTR protein, or eliminate existing amyloid fibrils that are already formed. For AL pathophysiology, as we mentioned, there is a plasma cell dyscrasia that's leading to an overproduction of immunoglobulin light chains, kappa or lambda. These chains then misfold, aggregate, and form amyloid deposits in the myocardium. In addition to this deposition, the light chains are also directly toxic to the cardiac myocytes, which contributes to the overall pathology. It is a multi-organ system hematological disease, with the kidney and heart predominantly affected. The heart is affected in about 60 to 70% of cases. Now, it's also considered a hematologic emergency, with prompt referral for hematology, and initiation of chemotherapy is warranted in all cases. In contrast, in ATTR amyloidosis, the precursor protein in question is transthyretin, which is predominantly produced in the liver, with normal responsibilities of transporting thyroxine and vitamin A throughout the body. Now, transthyretin is normally a soluble tetrameric protein, which then dissociates into monomers, which form amyloid fibrils that are insoluble and then deposit in the myocardium. For patients with wild-type disease, the etiology of amyloidogenesis is unclear. It's thought to be a consequence of aging, and the phenotype is almost always cardiomyopathy. For variant TTR, there are genetic mutations that lead to a more dysfunctional TTR protein that's more prone to dissociation. Now, the pattern of inheritance is autosomal dominant, and there's a variable and incomplete phenotypic penetrance, again, dependent on the specific mutation involved. There are over 120 mutations that are identified. The most common one worldwide is the V30M mutation, and can either present as polyneuropathy, cardiomyopathy, or both. And then the V122I mutation is identified in 3 to 4% of African Americans, and it does have a variable phenotypic penetrance, but almost always presents with cardiomyopathy. So patients can present with a multitude of non-specific symptoms, which really makes identification of the disease challenging. They can have standard heart failure symptoms like dyspnea, fatigue, or edema. Conduction abnormalities are often present, and they're predominantly bradyarrhythmias and AV block. And then extra cardiac symptoms are almost always present, depending on the type of amyloidosis, and can include polyneuropathy, GI complaints, and proteinuria. Now, the workup for a patient with potential cardiac amyloidosis always starts with a clinical suspicion. There are various clues and red flags, what they call them, that patients can present with to steer the clinician into thinking this may be amyloidosis. Patients can have a history of carpal tunnel, lumbar spinal stenosis, history of biceps tendon rupture, and these tend to be very common with wild-type TTR. Proteinuria and nephrotic syndrome are almost always present in AL amyloidosis and tend to be the first presenting sign. Periorbital purpura and macroglossia are only present in AL and are pathognomonic. These patients tend to not tolerate standard heart failure therapies very well, like ACE inhibitors or beta blockers. As the disease progresses, you may see patients who are hypertensive and now their blood pressure is starting to normalize or even become low, requiring de-escalation of antihypertensives. You may also see a mild chronic elevation in troponin. Autonomic and peripheral neuropathy can often be the first presentation of variant TTR and is common in both variant and AL amyloid. Lastly, there are imaging and diagnostic testing clues that can reveal clues for the presence of cardiac amyloidosis. Now, it's important to note that appropriate diagnosis is necessary and early diagnosis is necessary. Patients need to be diagnosed appropriately at the right subtype because the treatment of AL and ATTR are vastly different. And secondly, they need to be diagnosed early because survival is much poorer once there's significant cardiac involvement, and the benefits from the treatments that we'll discuss later are most pronounced when they're started early in the disease process. So after you suspect cardiac amyloidosis, there is a vast diagnostic armamentarium to help you establish a diagnosis. Cardiac biomarkers and renal function should be obtained in all patients, and they're used to stage the severity of disease and patient prognosis. An electrocardiogram may show pseudoinfarct patterns or low voltage, though it does lack sensitivity. Echocardiography may show increased ventricular wall thickness, biatrial enlargement, and on strain imaging, a characteristic feature of apical sparing of longitudinal strain. Cardiac MRI can be obtained in addition to echocardiography for better tissue characterization and may show diffuse late gadolinium enhancement, increased extracellular volume, and the inability to null the myocardium. Nuclear scintigraphy with a technetium pyrophosphate scan can be used to non-invasively diagnose transthyretin cardiomyopathy only in the absence of monoclonal protein, and then a grade 2 or 3 uptake is diagnostic for this with specificity approaching close to 100%. Lastly, tissue biopsy is still considered the gold standard and can be used in all cases where there's still uncertainty despite the above tests, and is always required to diagnose AL amyloidosis. Now, if the patient presentation and the cardiac diagnostic suggests cardiac amyloidosis, arriving at a diagnosis is achieved by following the diagnostic algorithm. The most important initial step is to rule out AL, again, for 2 reasons. One, it's very progressive, patients need to be treated right away, and the presence or absence of monoclonal proteins dictates the next step in the algorithm. So screening for monoclonal proteins includes both a serum and urine immunoelectrophysiology, so electrophoresis plus immunofixation, and a serum-free light chain assay. If any of these are abnormal, the clinician should proceed to the left side of the algorithm with a hematology referral, tissue biopsy, followed by Congo red staining to identify amyloid deposits, and then tissue typing to identify the subtype of amyloid. Now, a negative monoclonal protein screen has a sensitivity of more than 99% and can rule out AL. The clinician should then proceed to the right side of the diagnostic algorithm by ordering a technetium pyrophosphate scan. If the scan is positive, the patient can be diagnosed with transthyretin cardiomyopathy, which is then followed by genetic testing to differentiate between wild type and variant disease. If the test is negative, transthyretin cardiomyopathy is unlikely, though one can pursue a biopsy if the clinical suspicion is still high. I also do want to mention that some patients with TTR can have other monoclonal gammopathies, and some patients with AL amyloidosis can have uptake on the PYP scan. This is why this PYP scan can only be used to diagnose transthyretin cardiomyopathy in the absence of any monoclonal proteins. Now, treatment for cardiac amyloidosis is threefold: management of heart failure symptoms, treatment of arrhythmias if present, and then treatment of the underlying disorder with disease-modifying therapies. General management is supportive in nature. Loop diuretics with or without mineralocorticoid receptor antagonists are used to maintain euvolemia. Anticoagulants, both warfarin and DOACs, are given for patients with AFib or aflutter, and then given the high thromboembolic risk that's seen with amyloid, they're given irrespective of risk scoring. And then amiodarone is the antiarrhythmic of choice. Now, as mentioned earlier, most heart failure therapy, the standard heart failure therapies, are not tolerated well, especially the rate lowering agents. These patients have concomitant autonomic dysfunction and already have a labile blood pressure. Secondary, because of the amyloid deposition, they have a fixed stroke volume and rely highly on heart rate to maintain cardiac output. And so these agents tend to be tolerated very poorly. The non-dihydropyridine calcium channel blockers are especially problematic because they can also bind to the amyloid fibrils, can cause profound hypotension, bradycardia, heart block, and actually contraindicated in these patients. The goal of treatment for AL amyloidosis, again, is to stop the production of light chains from the bone marrow with chemotherapy. Now, there are various different regimens that can be used, but a common one is Cyborg-D, which is a combination of cyclophosphamide, bortezomib, and dexamethasone. Recently, there was a trial called the Andromeda trial that showed that adding daratumumab, which is a CD38 antibody that targets CD38 positive plasma cells, resulted in higher frequency of complete hematologic response and increased survival free from major organ deterioration compared with chemotherapy alone, and is not part of the standard of care. And then in addition to chemotherapy, select patients who are appropriate should be referred for autologous stem cell transplant. For TTR, treatment can be targeted in various steps in the amyloidogenic process. We can prevent formation of transthyretin with gene silencing therapeutics. We can stabilize existing protein with tafamidis or diflunisal. We can disrupt deposited amyloid fibrils with either doxycycline and tauroursodeoxycholic acid or ursodeoxycholic acid, and then with monoclonal antibodies. So gene silencing drugs are compounds that interfere with messenger RNA with the goal of preventing protein translation. There are two classes of drugs, the small interfering RNAs and the antisense oligonucleotides. They work very similarly and essentially bind to transthyretin mRNA, leading to its degradation and preventing the translation of TTR mRNA into functional protein. Patisiran was studied in the Apollo trial in patients with familial TTR amyloidosis with polyneuropathy and improved the neuropathy outcomes in the study. There was a cardiac subpopulation of around 126 patients, and showed that patisiran also decreased LV wall thickness, global longitudinal strain, and NT-proBNP. This led to the development of the Apollo B trial, which is currently ongoing in patients specifically with transthyretin cardiomyopathy. Inotersen is an antisense oligonucleotide. It was studied in the NEURO-TTR trial, also in patients with familial TTR amyloidosis with polyneuropathy. And then while it met its primary neurologic outcome, the evaluation of cardiac parameters showed no difference between the treatment group and placebo, and an ongoing open label extension trial is currently ongoing with this study. Now, TTR stabilizers are compounds that bind to transthyretin, prevent its dissociation into monomers, which is the rate-limiting step in the amyloidogenic process for TTR. Now, tafamidis is a selective oral TTR stabilizer that lacks NSAID properties and selectively binds with high affinity to the thyroxine binding site on transthyretin. It has been studied in both polyneuropathy as well as cardiomyopathy. Diflunisal is actually an NSAID that also exhibits TTR stabilization properties. Evidence supporting its use is mostly limited to non-randomized trials, which did show that diflunisal may prevent disease progression and may be associated with improvement in clinical outcomes. However, given that it is NSAID, the long-term risk of cardiovascular, GI, and renal toxicities may preclude use in some patients who already have heart failure and may have pre-existing renal dysfunction. It should also be noted that diflunisal is not approved for TTR polyneuropathy or cardiomyopathy, and its use is off-label only. So the tafamidis in the transthyretin amyloidosis cardiomyopathy clinical trial, the ATTR ACT, or commonly known as the ATTRACT trial, was a phase 3 randomized study in which patients 18 to 90 years of age with either wild type or variant disease were randomized in a 2:1:2 randomization to receive tafamidis 80 milligrams, tafamidis 20 milligrams, or matching placebo. The pertinent inclusion and exclusion criteria are listed on the slide for you. Now, the primary outcome of this study was a hierarchical assessment of all-cause mortality, followed by cardiovascular-related hospitalization over the duration of 30 months between the pooled tafamidis group, so both doses, against placebo. Key secondary outcomes were change in the 6-minute walk distance and change in the Kansas City cardiomyopathy overall summary. Then after completion of the trial, patients were offered enrollment to continue in a long-term open-label extension study. Overall, the baseline characteristics were well balanced, and the average patient is a 75-year-old white male with functional class 2 symptoms. 3/4 had wild-type disease, and the remaining had variant disease. The mean creatinine clearance was about 57. Median NT-proBNP was around 3,000. Median troponin I was 0.14, and the mean EF of 48%. So tafamidis was found to be superior to placebo in the primary analysis with a win ratio of close to 1.7. There was a 30% relative risk reduction in all-cause mortality compared with the placebo group, with survival curves starting to separate right around 18 months after treatment. Number needed to treat for this was 8 patients, a little less than 8 patients. Cardiovascular hospitalizations were also lower in the tafamidis group. Tafamidis also improved functional capacity as well as healthcare related quality of life, with benefit first observed after about 6 months of treatment, and the safety profiles between the two agents were similar. Now, the last thing you can do, you can target fibril disruption or use agents that can degrade and eliminate the already bound amyloid fibrils. One agent that can be used is doxycycline with either TUDCA or UDCA. However, the evidence behind this is very limited. There's really an unclear benefit, and given the high rates of intolerance to doxycycline that can be seen, it's not often used. Additionally, there are monoclonal antibodies in development, and they specifically target amyloid fibrils, trying to facilitate their removal via immune-mediated phagocytosis. Early phase trials are ongoing and may offer another potential treatment in this disease. So in addition to the current available treatments, this field is rapidly expanding with several phase 3 trials ongoing. Attribute cardiomyopathy is looking at another selective TTR stabilizer, acoramidis, or AG10, in 510 patients with transthyretin cardiomyopathy. As mentioned previously, Apollo B is looking at patisiran. Helios B is a phase 3 study looking at a subcutaneous small interfering RNA with planned enrollment of about 600 patients. And CardioTransform is a phase 3 study looking at a subcutaneous antisense oligonucleotide eplontersen in up to 750 patients with TTR cardiomyopathy. Now, additionally, there is a lot of excitement around gene editing. Currently, there's a compound, NTLA 2001, that's a CRISPR-based gene editing therapy So what this does, it essentially acts as a molecular scissor to go in and cut out the section of DNA that's responsible for making TTR. Now, this targeted knockout would prevent transcription, not translation, and would permanently stop the liver from making transthyretin after a single dose. Now, phase 1 trials of this agent is currently ongoing. Now, with all these data, all these treatment options available, we still don't know what the best so-called treatment regimen is. Tafamidis is the only one that's been approved for transthyretin cardiomyopathy and should be the initial agent in those patients. Diflunisal can be used for those who cannot obtain tafamidis. For patients with TTR polyneuropathy as well as cardiomyopathy, you can use either patisiran or tafamidis. And then lastly, the potential for combination therapy will need to be evaluated, and then if approved, be balanced with the high cost of therapy, which is the focus of the next section of the webinar. Thank you.
All right, hopefully you guys can see my screen. Sorry, I was having some technical difficulties. For the second part of this webinar, we're going to be focusing on TTR specific therapies, ensuring our patients have access to these medications. For this presentation, I have no disclosures to report. And by the end of this presentation, I hope you'll be able to assess the cost effectiveness of our new therapies approved for the treatment of TTR cardiac amyloidosis, as well as be able to recognize available medication access resources for patients with this disease. Now, notably, AL is beyond the scope of this part of the presentation just due to time, and we will be focusing on TTR cardiomyopathy, not polyneuropathy. When the TTR silencers and the TTR stabilizer tafamidis first came onto the market, the reception from the medical community was very positive. Clinicians were really excited to start using these therapies because before we had never had anything to offer these patients beyond supportive care. However, these medications are specialty medications and they are for a rare disease. And because of this, they carry a very large price tag. And within the cardiology community, we had never had to deal with one single medication with a price tag this large. We have expensive procedures and devices, but never one single medication like this. And so because of this, clinicians were justifiably concerned that all the patients that should qualify for these therapies wouldn't be able to have access to them. So before we talk about cost effectiveness, we have to first assess efficacy. And I'm not going to spend a whole lot of time of this because this was talked about in the first part of the webinar, but there's basically three mechanisms we can target. We can either reduce the production of mutant TTR, we could stabilize the TTR tetramer, or we can disrupt and remove amyloid fibrils. And the associated medications for that are listed below. And now that we have TTR-specific therapies, it's really important that we analyze the available evidence and be able to provide evidence-based recommendations. And this was done in a 2020 systematic review. And the studies that were included were randomized control trials, non-randomized control trials, as well as observational studies. And they had to be discussing TTR cardiomyopathy specific therapy. And then they also had to report on cardiovascular outcomes. You can see some of those important outcomes listed to the right side there. The authors concluded that tafamidis can be recommended with a high degree of certainty in our patients with TTR cardiomyopathy. And this was given a class 1 level of evidence B recommendation. And this was mainly driven by the results of the phase 3 randomized control trial ATTRACT, where we saw improvement in cardiovascular hospitalizations and mortality. So because of this, tafamidis can be used for both hereditary and wild type TTR cardiomyopathy. Their second conclusion was that patisiran may have a benefit in patients with hereditary TTR cardiomyopathy based on subgroup analyses. And they saw in these analyses that there was improvement in cardiac biomarkers as well as imaging, in addition to being associated with improved cardiovascular hospitalizations as well as improved mortality. And this was really exciting, and definitely the potential benefit needs to be confirmed in randomized control trials. And as discussed previously, this is ongoing in the Apollo B study. Other therapies have not shown a benefit in TTR cardiomyopathy and therefore cannot be recommended at this time, either due to no evidence or low quality evidence. And this includes inotersen, diflunisal, and AG10. Now, some of these are in ongoing clinical trials, and so with the results of those, we can revise these recommendations. But for right now, we're going to be focusing on tafamidis and patisiran for the rest of the presentation. Tafamidis was approved by the FDA on May 3rd, 2019, and it received fast track, priority review, and breakthrough therapy designations for meeting an unmet clinical need in this population. It also received an orphan drug designation because it's indicated for a disease that affects less than 200,000 patients in the United States. It is indicated for the treatment of wild type or hereditary TTR cardiomyopathy, and it is provided as either tafamidis or tafamidis meglumine, so either as Vyndamax or Vyndaqel. It is distributed through specialty pharmacies, and it has a high estimated annual cost of $225,000. Now, notably, this is the average wholesale price or the list price. So this does not include any discounts or rebates provided by the manufacturer. So no patient or payer is going to pay this much, but these patients will still have a very high out-of-pocket cost. Now, before we move forward, I do want to show you that even though tafamidis has this high out-of-pocket cost, it is similar in cost to other oral specialty medications. And you can see some examples highlighted on the screen, but I especially want to look at selexipag or Uptravi, which is a medication that we use for pulmonary hypertension that a lot of us are familiar with. And you can see here that the estimated annual cost of Uptravi is $277,000 a year. So tafamidis, again, is within line with other specialty medications, but that doesn't mean that it doesn't have a high out-of-pocket cost. Now we're going to be looking at cost effectiveness of tafamidis. And this was done by Kazi et al., and this was published in 2020. And they created a Markov model for patients with TTR cardiomyopathy. And they compared tafamidis versus usual care, which was no TTR specific therapy, basically supportive care. And their primary outcome here was the lifetime incremental cost effectiveness ratio, or the ICER per quality adjusted life year. Looking at the model, we can see for the model inputs, most of this was based off the ATTRACT trial, but they additionally looked at things like published literature, FDA review documents, and national claims information to construct it as well. On a monthly cycle, patients had three options. They either lived with heart failure with a declining quality of life depending on what stage of disease they had, or they experienced a cardiovascular hospitalization or death. The simulated population here was based off the ATTRACT trial, mean age 74.5 years, 11% are female, and notably they excluded patients with NYHA class 4 heart failure, patients with an implanted left ventricular assist device, or patients with a GFR less than 25. Some important other model assumptions were that from the time 0 to 30 months, the projections are going to be based off the ATTRACT trial. And this is because ATTRACT only followed patients for 30 months. From 0 to 18 months, survival was equivalent in the intervention and the control arms. And this is because if you will recall from the mortality curves for the ATTRACT trial, there was no difference in survival until about 18 months. And that's when you saw those curves separate. From 18 to 30 months, the death and cardiovascular hospitalization rate are pulled directly from ATTRACT for both the control and the intervention group. Of course, after 30 months, we don't have any data, so we have to extrapolate. And 3 different cases were presented. The first was a base case analysis, which was basically a best case scenario that assumed the benefits of tafamidis were sustained beyond 30 months. Then they looked at an intermediate case where the effectiveness of tafamidis waned after 30 months, and there was going to be no difference between the intervention or the control group at month 90. And then finally, they had the worst case scenario where tafamidis becomes ineffective after month 30. Some other important assumptions are that 1 year of tafamidis was going to cost $225,000. Again, that is the average wholesale price or the list price, notably not including any discounts or rebates in that number. Here you can see the mortality curves, the proportion alive over months, and of course the base case or best case scenario shows tafamidis in the best light, and you have declining mortality with the intermediate and then the worst case. Focusing on the base case, you can see that the mean survival in the control group was 3.46 years versus in the tafamidis group was 5.43 years. So significant survival, exactly like we saw within the ATTRACT trial. The quality adjusted life years generated were 1.29 QALYs, which is a pretty impressive QALYs generated. But unfortunately, this came at an incremental cost of $1,135,000. And when they calculated the ICER per quality adjusted life year or quality ratio, this was $880,000. So for each quality adjusted life year that you gain, you pay $880,000. Not surprisingly, this is above conventional cost effectiveness thresholds, which are typically at $100,000 per quality gained. And the authors suggest that a 92.6% price reduction would actually be required to a cost of $16,000 for tafamidis to be cost effective. The authors' conclusions were that tafamidis significantly improves survival and does have a very large quality gained. And because of this, I do think approval and use for TTR cardiomyopathy is justified due to that mortality benefit. However, I do think it's also obvious that the ICER per QALY greatly exceeds conventional cost effectiveness thresholds. And although it's true that the cost is comparable to other specialty medications, and although it's also true that conventional cost effectiveness thresholds are really not well suited for specialty medications or medications for rare diseases due to the high list price, I think this still leaves patients with really high out-of-pocket costs, and it can affect their access to care. Now to focus a little bit more on the real world experience with tafamidis and what our patients are actually seeing when they try to fill these medications. And this was presented in 2 publications. One is a research letter and one a letter to the editor. And the first one I want to look at was done by Masri et al. And this was a retrospective review in 50 patients with TTR cardiomyopathy. Notably, 43 patients or 86% of patients were able to receive and start on tafamidis therapy. When we look at the insurance coverage here, you can see most patients are Medicare patients, 76%. And the median time from prescribing to mailing was 26 days with a range of 12 to 78 days. And that range reflects the time it takes to get financial assistance for some patients. The median out-of-pocket cost prior to assistance was around $1,900 a month with a range of $250 to $3,100. And we look more at the financial assistance piece, 15 patients or 30% of patients were able to receive grants, whereas 13 patients or 26% of patients were eligible for manufacturer's assistance. Now, those patients who received financial assistance had a $0 out-of-pocket cost, but the ones who did not qualify for assistance had a median copay of $250 per month, but again, very wide range, anywhere from $39 to $1,700 per month, and a mean of about $1,600 per month. So the authors' conclusions were that attainment of tafamidis depends heavily on financial assistance programs, and our patients who are on a fixed income, like our fixed income seniors, but who are above assistance thresholds may not be able to afford the medication. And these results really are echoed by the second publication done by Cuddy et al. And this was a retrospective review, 80 patients with TTR cardiomyopathy. And they broke down the cost per 30 days a little more. So they found that 26 of their patients, or 34%, had a copay of less than $100. But 66%, or 51 patients, had a copay greater than $1,000, with a range of $1,010 to $14,000 per month. They again broke down the financial assistance piece a little bit more. They found that 16%, or 12 of their patients, were eligible for manufacturer's assistance, though they did note that 4 patients did have pending applications. And then 17%, or 13 of their patients, received grants, but 25% of their patients remained ineligible for any sort of financial assistance. And after assistance, still 23 patients, or 30% of their copays, remained greater than $1,000. And unfortunately, 9 of those patients were never able to start tafamidis due to cost. So again, their conclusion was that the current cost of tafamidis should be reviewed, as the financial burden is significant for most patients. And just within our clinic here at Cone, I would say that this is pretty accurate. Most of our patients are Medicare patients, and most of them tend to have a copay of anywhere between $1,000 to $3,000 per month. And if they are under the income thresholds for grants or manufacturer's assistance, we can usually get them assistance, but if they're above those thresholds, it's really difficult for their patients and they may not be able to start therapy. Now to take a break from that and switch gears to talk about patisiran for a little while. Patisiran received FDA approval on August 10th, 2018. Similarly to tafamidis, it received fast track, priority review, as well as breakthrough therapy designations, and also an orphan drug designation. It is only indicated for the treatment of hereditary TTR polyneuropathy, and it's dosed at 0.3 mg/kg as an IV infusion every 3 weeks. It has no REMS requirement, unlike the other TTR silencer, inotersen. And it does require specialty pharmacy distribution for our patients who qualify for home infusion, or patients can get it at an outpatient infusion clinic. And this is going to be driven by insurance coverage. The estimated annual cost here is $345,000. Again, this is the list price with no discounts or rebates applied. The cost effectiveness of patisiran was assessed via an ICER review, and it was compared versus best supportive care for patients with hereditary TTR polyneuropathy. Of course, we can't be looking at cardiomyopathy because that's not an FDA-approved indication here. And they concluded that patisiran is superior to best supportive care. You can see improved QALYs at 6.54 versus only 3.11 for supportive care. But similarly to tafamidis, it does have, unfortunately, it's not cost effective with an ICER per QALY ratio of $835,000. So the authors say that the price should be decreased down to a level that aligns fairly with potential benefits provided by the therapy. Now to look a little bit more into medication access. How do we actually get these patients the medication at an affordable cost? And the most important question to ask is what type of prescription insurance that patient has, if any at all. And that's going to really determine what options we have. For our commercial patients, basically no Medicare or no Medicaid, most of those plans will require prior authorization, but once that is approved, those patients are eligible for copay cards and they will have a $0 out-of-pocket cost. For our Medicaid patients, you do need to check state-specific formularies and prior authorizations may be needed, but once approved, patients can get these medications at the same cost as other medications on the Medicaid formularies. The true issue comes with our Medicare Part D patients. Again, most of these plans will require a prior authorization, though I will note that patisiran is usually billed under Part B because it's an infusion and not Part D, but that does depend on the patient's insurance coverage. Once authorization is obtained and you can see the copay, if that copay is too high, you can consider applying for a grant. This is a third-party organization that's going to provide money for these patients to address their copays. And then if the grants are closed, you can apply for manufacturer's assistance. And finally, for our uninsured patients, these are the most straightforward, and you just go directly to manufacturer's assistance. To talk a little bit more about grants, only patients with insurance are eligible to apply. So we cannot use grants for uninsured patients. And additionally, most grant foundations will stipulate that the patient has to have Medicare. They cannot have commercial insurance. You can find open or available grants via the Fund Finder website. And this lists all the different disease states that have grants available. So we're going to be focusing on the Amyloidosis Fund. And both the PAN Foundation and the HealthWell Foundation will provide grants to these patients, and they're about $8,000 per year. So you will need the patient's social security number, household size, household income, as well as the Medicare insurance card information to apply. And once you apply, you will get that decision in real time, and then you can then take those pharmacy benefits information and provide it to the patient's specialty pharmacy. Now, importantly, grants are going to be provided on a first-come, first-served basis, and they do close once available funds are depleted. Most of the time, the grants are closed, so you'll need to add the patient to the wait list. Once they open, you'll get an email. You can apply for that patient. I will say you do have to be pretty quick. The last 2 times the PAN Foundation was open this year for Amyloidosis Fund, the grant closed within 24 hours. If possible, I would consider obtaining multiple grants for your patients and alternate billing on a monthly cycle. And this is because you can see each of these grants is only going to give the patient $8,000. If that patient's copay is $2,000, that's not going to last the entire year. So because of this, when I'm able to, I'll get them 2 grants, and then I'll talk to the specialty pharmacy, and I'll have them alternate grants on a monthly cycle to extend the life of those grants. You do have to bill the grants at least once every 120 days, or the account will be inactivated. And that's why you need to alternate the grants rather than just draining one and then using the other. For manufacturer's assistance, these are available for either our uninsured or underinsured patients, which are patients who have Medicare but with a high copay. And we use them when the copays are too high and our grants are closed. The companies will have income cutoff requirements, and these are going to be based on the number of people in the household. And these will differ between companies, but it's usually anywhere from 400 to 500% of the federal poverty level. You will need the patient's signature and provider signature, as well as household size and income before submitting the application. And that application can be found on the manufacturer website, and you submit it through the manufacturer hub services, and their case managers can help with the processing of those applications. Looking a little bit more into the manufacturer involvement, the different hubs are Alnylam Assist for patisiran and Vindalink for tafamidis. Again, both of these have case managers to help with application processing, but they also can provide medication or disease state education, as well as connect patients to support groups and do benefits investigations. And patisiran, they will also look and see if the patient qualifies for home infusion or needs to go to an outpatient infusion center. Patisiran has what's called a quick start program, which can be really helpful. They'll provide 3 doses of patisiran at no cost while the patient's insurance coverage is investigated. And so where this is helpful is if you have a prior authorization that is denied and you have to submit an appeal, the appeal process can be really lengthy. So this can help your patient go ahead and start therapy. Tafamidis has a similar program called the Interim Care Program, which gives 60 days of tafamidis at no cost to the patient while they look into coverage. Both of the foundations have copay cards for our commercial patients, where they'll have a $0 out-of-pocket cost. And again, both of them have patient assistance programs that give the medications at no cost for patients who are below the income thresholds. And finally, I do want to highlight some specialty pharmacy services. You can go directly through the manufacturer and submit the start form or the enrollment forms that way. But you don't have to if you have a patient who you don't think is going to qualify for manufacturer's assistance. You can submit it directly to a specialty pharmacy, either one that is associated with your clinic or hospital, or one that's an independent one that maybe the patient's insurance prefers. Once the specialty pharmacy receives the prescription, they will do a benefits investigation, and they'll contact you if a prior authorization is required. Once that is approved, they can help with financial assistance investigations. So they can help obtain copay cards as well as grants. And then they can also let you know if manufacturer's assistance will be needed, and then you can go back and apply for manufacturer's assistance with that patient. Once it's clear that the patient will be using the specialty pharmacy, a pharmacist is going to complete first fill counseling. And that can either be the pharmacist at the specialty pharmacy, or if you're associated with a clinic, it can be the clinical pharmacist. And that's where the pharmacist would talk about both medication and disease state education for that patient, make sure they understand the medication and why it's important to be taking it. And then the main benefit, I think, is ongoing management. You have the pharmacy technicians making refill calls to the patient, making sure they're adherent to therapy, getting the medication shipped out, and just generally checking in on that patient. And then you also have the clinical assessments that are done usually every 3 months by the pharmacist, again, making sure that patient is tolerating therapy and being able to triage any issues. So I believe the new TTR therapies are effective. Unfortunately, they are not yet cost effective for TTR. However, I do think they address an important unmet clinical need for these patients, and I think we need to be evaluating all patients for these therapies. And while it's true that these therapies, the cost is in line with other specialty medications, and it's also true that the cost effectiveness thresholds that we usually use are not well suited for our specialty medications or medications for rare disease due to the high list price, I still think it's obvious that significant price reductions are going to be needed to increase access to this therapy. Because right now, medication access depends heavily on insurance type and annual income. We can use things like copay cards, grants, and manufacturer's assistance to address these high out-of-pocket costs. But obtaining these is very time intensive, and at the end of the day, not everyone will qualify. However, I do think this added effort is worth it to ensure our patients have access to these therapies. That's all I got.
Well, thank you so much, Dr. Kemp and Dr. Landup. That was a lot of good information about cardiac amyloidosis. So we do appreciate your time this evening. We still have about 10 minutes. And so we want to make sure that we allow for any questions at this time. So if you have questions, feel free to either raise your hand so that we can kind of call on someone to go ahead with their question, or you can type a question in the chat box. And we'll give people some time to think of some questions. Okay, so I see one question from Justin Joy, who says, in your practices, what kind of monitoring parameters do you measure for tafamidis? And then there are some examples like, do you do prealbumin levels or other?
Yeah, we really don't measure nothing specific with tafamidis. You can get prealbumin levels, and those who are not familiar, prealbumin is transthyretin. And you can actually see an increase in those levels, which is a good thing because you're getting more of the stable tetrameric form rather than dissociation. But we don't use it as a marker of clinical efficacy or anything like that. And you know, compared to placebo, is one of those medicines that really, I've seen a few instances of diarrhea, but really tolerance has not been an issue at all. And clinical efficacy just based on following the patient with regular cardiac biomarkers or just patient assessments, symptomatic assessment.
Thank you. Is that pretty similar in your practice, Dr. Kemp?
Yeah, we generally are not measuring any sort of thing like prealbumin levels. We will measure cardiac biomarkers, but that's more what we would do for any of our patients, NT-proBNP, we'll repeat echoes, we'll of course be assessing their NYHA class every time they come in, but there's no specific monitoring for tafamidis that we look for.
All right, thank you. Are there other questions? So there's another question in the box from Michael Shermer. I'm sorry if I mispronounced that. Since access to tafamidis is a big time commitment, what is the average turnaround time for confirmed diagnosis to patients receiving the drug?
So that is a wonderful question, and it really depends on the patient's insurance. In general, what I found is now that tafamidis has been on the market longer, prior authorizations go pretty smoothly from what I've seen, and those generally return in about 24, maybe 48 hours, and almost all of them are approved for at least our patients. So that issue has been taken care of, where I know a lot of people in the past had issues getting those approved, and they would need to do an appeal, and it was a very lengthy process. So right now that part is taken care of. If the patient then has commercial insurance or Medicaid, or then I think those patients can probably get the medication within a week, very quick turnaround. For patients who have no insurance, I would say probably about 2 weeks, because I would need to submit the manufacturer's assistance application to Vindalink, who would process that, and they're actually pretty quick, especially for the uninsured patients, so probably a week to 2 weeks. The real issue is our Medicare patients, because in general, most of the grants are not open. We have to put patients on a wait list. If the grants are open, similar to a commercial patient, I can get them that medication within 7 days. But if the grants are closed, then I'll put the patient on the wait list and apply for manufacturer's assistance. And that is generally slower than for uninsured patients, because they will need to do a benefits investigation. So I would say that's the patient that would be more like 2 to 3 weeks to get the medication. And if they don't qualify for manufacturer's assistance, we may have to wait for the grants to open up, and that's when you start seeing it takes you months to get the medication. So hopefully that was helpful. There's a really wide divide, as you could see from the ranges and some of the real world tafamidis experience, between patients who can get it within a couple of days and patients who have to wait months.
Thank you. Any other questions? We have just a few minutes left. All right, I don't see any hands raised, and I don't see any more questions coming through the chat. So thank you both again for your time presenting to us this evening on this topic, and thank everyone who is in attendance this afternoon for joining us in this virtual space. If you have any questions or comments or concerns afterwards that you'd like to reach out to our speakers about, you may feel free to do that, or you may reach out to myself or Sheila, who helped coordinate this event, and we can get those questions to our speakers to respond back to you pretty quickly. So thank you all for your time, and I hope you have a good rest of your day and good school years if you're starting school back soon. All right, thank you.